Good afternoon, everyone. Welcome to Ethics for Lunch for March. My name is Mark Hughes. I, with Cinda Rushton, co-chair the Hospital Ethics Committee, and the Ethics for Lunch is sponsored both by the Ethics Committee and the Berman Institute of Bioethics. So an opportunity to talk about clinical ethics issues, and we always bring a panel of experts to help discuss cases or issues. And we also invite you, the audience, to participate. So today we have a series of cases that are going to be challenges in the assessment of decision-making capacity. So can patients make their own decisions? Do they have the capacity to do so? And when we're assessing that, there might be communication strategies or other things that need to be accomplished to make sure that they do have that ability. So those would be the cases we'll discuss and invite your reaction to them. I'll just run through some CME slides first, just to get everyone situated about what we do. So this is available for credit. So with the CME office, that's designated for 1.25 AMA credit hours. So you can, once you send your code in, which I'll show you in a few minutes, that's available for the CME office. We have the disclosure policy that if there are any conflicts of interest that need to be known about, or potential use of off-label medication, that we make that known to you. I don't anticipate we're going to be talking about any non-approved uses of FDA medications. And we'll show you the conflict of interest shortly. This is available for anybody in the hospital community, so thank you all for coming. We have the general activity objectives for the whole Ethics for Lunch over the entire year. So really just trying to improve education and communication among stakeholders and healthcare. And for today, no one has any financial or commercial entity relationships that you need to be aware of. And for today's presentation in particular, we're going to, as I said, talk about assessing decision-making capacity, the role of members of the healthcare team in assessing that capacity, and also the role of family members in the decision-making process. We always anonymize or make cases based on real life, but not actual particular individuals. And if there is any opportunity to talk about private information, there's an expectation that we, as well as you all, will keep that private information confidential. For today, if you haven't done this before, this is the phone number that you would use to send in the code, the 844-980-1555. And for today, our code is 51357. Keep that up for a minute for those that did. Okay. This is also available on the CME website, so you could check there for other activities. And have our panelists introduce themselves. So we will just run down on that.
I'm Tasha Williams. I'm one of the senior social workers, and I'm in oncology.
Sharon Owens, I'm the director of nursing for surgery and physical medicine and rehab, and I'm going to go to the ethics team.
My name is James Mattis. I am a chaplain fellow here at the hospital and also with the family ethics.
Hi, my name is Jessica Estiva. I'm associate senior counsel for Johns Hopkins Health System. I primarily deal with HIPAA and privacy, but I also take attorney on call.
Okay, great. So we've already talked about our objectives, and I want to point out that we do have a hospital policy on assessment of decision-making by patients. So we might refer to some of the excerpts of this in this presentation, but helpful information, for the responsibilities of all healthcare team members doing this assessment as well as we have appendices that help in going through a algorithmic process of first determining who might need to be assessed for capacity, as well as if they don't have capacity, we determine to be their healthcare decision maker. And the other policy to be aware of is the health system informed consent policy. In particular, for Appendix B, talks about the Maryland-based hospital entities and the things we need to know, how the law works with regard to informed consent and determining capacity and determining a surrogate decision. Okay, so we're going to talk about decision-making capacity. And the four criteria when you're assessing capacity are these. So obviously there's need to be disclosure of information by the clinician, but then to know whether the person is able to make their own decisions, they first have to have an understanding of that information. So can they comprehend what's been delivered to them? They have to have an appreciation of that information. So can they take it and sort of put it in the context of their own life? So that, saying that, yes, I do have an illness, this is what the doctor or nurse or others are telling me, and then I, put that, who I am as a person. They have to have reasoning ability. So if you are doing informed consent for a treatment, an intervention, a surgery, whatever it might be, they have to hear about the options that are available to them. So there's that option that might be recommended, but then are there alternatives? And then compare those in light of the pros and cons of each of those options in the context of one's own value system to decide what's going to be right for them. So that reasoning ability about those options. And then ultimately communicating the choice. So coming up to a decision, this is what I decide based on the information I've been given, my understanding of it, my reasoning about it. This is the path I want to pursue. So the clinician that is doing the informed consent has to make sure that the person has these four capacities. And when you're, there's questions whether the person might or may not have capacity, and all patients should be anticipate to have capacity until proven otherwise. But if you're doing a capacity assessment, you first of all have to say, well, what's the decision that needs to be made? So having a clear idea about that, trying to optimize the environment so that the patient can hear the information, process it, sort of making that as private as possible, a quiet setting to accomplish that. And obviously, if it's communication, it has to be done in the patient's primary language, whatever that might be. And then we use interpreters to help with that process if they don't use English as their primary language. Really define what the choice is for the patient with those weighing of the options. And that's the pros and the cons and those alternatives. A helpful appendix in our policy, and we reference Paul Applebaum is a forensic psychiatrist that has done a lot of work on decision-making capacity. He refers to it as competence. Competence we generally view as something that the law determines. A judge will determine whether the person is competent to manage their affairs. And if they're not, they might need to have a guardian put in place. He calls it competence to consent to treatment in this article in New England Journal, but it's those four criteria. And there are various questions that you might use to get at those four criteria, as well as some additional comments that I would refer you to the table for. And then, so it might be, the physician, nurse practitioner, physician assistant that is doing the informed consent, but all members of the healthcare team, the interprofessional team, have a role to play in assessing a patient's capacity. Because the patient might talk to other members of the team. So you're going to be able to judge whether or not they have the understanding, how they're reasoning through things and so on. So that's why we have our panelists from the various disciplines to help with that process of assessing capacity. All right, so here's the first case for you. This is KP. He's a 62-year-old male with a history of hypertension, diabetes, sickle cell anemia, and peripheral vascular disease. He presents to the emergency department with foot pain and is diagnosed with wet gangrene of his foot. He has been seen intermittently in outpatient vascular surgery, and those surgeons have previously recommended lower extremity bypass surgery. But at those outpatient visits, he had declined that. He has now been lost to follow-up. He hasn't continued to go to the vascular surgery appointments up until this presentation in the emergency department. So during his initial foot exam in the emergency department, he told the resident physician that it felt like she was being too rough in examining his foot, and he angrily told her to just go ahead and do what she had to do to examine it. The resident felt a little uncomfortable with his anger and stopped the exam early due to this comment. They called the vascular surgery consult, seeing that there was this concern for gangrene. They called the vascular surgery consult, who came down to the emergency department. The vascular surgery resident assessed the patient, recommended that he have surgical treatment of the foot, and the possibility that, given the extent of the gangrene, he might need an amputation. KP, the patient, refused the surgery, declined. There was also the possibility that if you're anemic and you have more blood loss during surgery, you might need blood products. He said he would not accept any blood products under any circumstances. He didn't give any religious reason for the refusal of blood products. There was often also the offer of bloodless medicine to see him to help manage if he were anemic. He declined that consultation. That first resident that had gone down and proposed the surgery and had tried to obtain consent and said, "I don't want to see you anymore." So, in essence, fired that resident. The vascular surgery team, called then the chief resident and the attending physician. They went and saw the patient, had a conversation with him. He continued to say, "I do not want surgery under any circumstance, even if my life was at stake." So they were sort of describing what could be the consequences of this gangrene, and it got worse. When asked to verbalize his understanding of the risks, he declined to answer. He stated he didn't want to say the risks out loud out of concern that they would then come true. He stated if you were meant to die, then that was God's choice. And he said, the vascular surgeon, do all you want, you're just recommending surgery because you just want to make money off it. So lots of issues with KP and try to manage his vascular disease. So let's turn it over to the panelists. We'll have Naja go first. What do you think about this?
Absolutely. I think there's a lot to unpack there. And one of the first things I see is that history of sickle cell. And one of the first things we encounter in that case is immediate mistrust of that first resident. And so my thoughts go to how do we help establish that this person actually trusts us, right? And if we can't do that with him, my next thought as a social worker is what is his support system? Who is connected to him to help us communicate with him in a way that's helpful and helping us to make sure that he understands what's happening. And B, making sure that he has that support system here, because these are obviously very serious decisions, and to be making them in a situation where you're one alone and maybe two don't trust the people who are giving information is a bit challenging.
As I look at this from a chaplaincy perspective, there are a couple of mentions of religion and God here, and so as I look at this in a little bit more detail, the first thing that kind of pops out to me in that regard is that this is not necessarily a case where religion really comes into play. It says that he did not give a religious reason for refusal of blood products, but it also says that his statement was that if he were meant to die, that was God's choice. Again, that's not necessarily that has like a tone of religious language, but that can just be another way that a patient is saying, "I'm resigned to whatever happens." It doesn't necessarily mean he's very religious. It doesn't exclude that. And I think if there were reason to suspect that was part of the reason, then certainly call in a chaplaincy consult. Let's see what's going on here. His decision making. So the other thing that pops out to me is a couple of the things that might suggest that there's a need to assess his capacity is one is to be sort of inconsistent behavior over time, and not symptom is a sickle cell patient, so we know that he's been seen by physicians in the past. We know for sure, based upon this history that we've gotten here, that he has refused large vascular surgery in the past. It was recommended in the past. So his current refusal for that, again, actually shows some consistency. But if that's one thing to consider, another thing that might suggest a need for determining his capacity is an unwillingness to engage in discussions about things. So we do see that a little bit, right? I mean, we see that, you know, he doesn't want to verbalize the risks, doesn't want to talk about it. But then in the next sentence, he says, if he's going to die, so be it. So there is a little bit of an understanding there of the risks. We just don't really know to what level. So further discussion might be warranted in that regard as well.
So from a legal perspective, the courts have uniformly held that as long as a patient has capacity, they have the right to refuse treatment, even if the result may clearly involve death or serious bodily injury. People who have capacity have the right to make bad decisions, just like you or I. And that's why when we have clinicians or providers or staff call the attorney on call or call attorney for legal assistance in cases like this, the first question that we usually ask or expect to have answered is, does the patient have capacity? Oftentimes, as we're kind of discussing now, it seems like it's not always a very straightforward answer. There's four, I think, elements that you can evaluate a person's capacity using, and it can change from one day to the next, which is why it's really important to, as others have referenced, somewhat try and establish a baseline. That helps by talking to providers who have seen the patient before, talking to family members, who know the patient's mindset and concerns. But at the end of the day, when legal is asked to give input on this, oftentimes we'll be put in a position where, unfortunately, we can't really assist with determining capacity. We can help talk through what the outcomes of the decision can be, whether that means if he does have capacity, is he allowed to say, nope, I don't want any blood transfusions, I don't want any amputation. We can confirm those decisions. If we lack capacity, what the next step might be. But since we're not there, we're not seeing the patient, we don't have any background, oftentimes we're asked to, assist with that. It's a little bit tricky from our perspective. But obviously from a legal perspective, it's a really key, important question.
So, in addition to trying to find his support system and people that have cared for him in the past, even though he's in the emergency department, there are other people caring for him. So you can look to other team members like nursing or social work or pastoral services. Have they been able to develop a rapport with him and trusting? And has he been involved in other decisions since he's been here in the emergency department, like asking him, we need to put an IV in? Has he been able to talk through that with the staff, or has he consented to having blood drawn? Has he been able to have a discussion about some of these other things that are happening with him to identify, is he able to make some decisions? Because as we know too, decision-making capacity does vary with different decisions. So, kind of how can we continue to develop that rapport with him and get some of those, care things done for him as he's in the emergency department?
I think one of the things we also have to be comfortable with when we do decide that somebody has capacity is if we don't agree with that decision, right? Because that was brought up. People do have the right to make bad choices. And I think in healthcare, sometimes we struggle with that when we see someone making choices that are going to be potentially harmful to their health.
And it's a balance, right? You want to be able to give them time to really, process that information, time to have him have an appropriate support system around him. But yet also not feel like he's being involved into a certain decision because they yeah.
So let's say the patient was having foot pain while he came to the emergency department. Let's say he's agreeable to hospital admission for pain management, but he's still saying, I do not want surgery. Maybe he is agreeable to having an IV placed. Maybe he's agreeable to getting blood drawn for lab tests. But beyond that, he's just not going to communicate about risks and benefits of surgery. Would there be any other things that you would do once it's in the hospital, besides the things you mentioned? Would you ever reach a point where if he's, got his pain under control, that the team could say, well, if you're not going to have surgery, we're just going to discharge you home, even knowing that your foot is not in good shape?
So I guess, again, attorney, my concern is always with documentation and making sure that we have documented all of our attempts. So if it means documenting from various staff members, putting in separate encounters, indicating that they've had conversations about the risks and have met their indifference or an inability to listen to the potential alternatives that seem to be volunteer, but that documentation is really important. Also, oftentimes, psychiatry can be a consult, and oftentimes as a last result, we in legal will recommend getting that. It's again, not necessary. Psychiatry is the only area that can assess capacity, of course, but it buys us time. And if it means having that additional documentation in the record that the patient was assessed by psychiatry and was found to have capacity, it just again bolsters up that documentation in the record.
And I would say, if you've been able to get in touch with a provider that has a long-term relationship with him, and that person has gone through the risk and the benefits and what needs to happen, and the patient says no, then yes, I would determine a discharge plan for him. It's not what we think needs to happen, but if he has capacity, he seems to understand, what may happen to him.
And I don't think we can underestimate the value of, if there are any other family members, or there are any friends who come and visit in the hospital, or if he's okay with us talking to someone on the phone, just getting an idea of his personality, if these are consistent patterns of decision making for him, based upon who he is, what his values are. It's just that can shed so much insight into this case. And social work, I'm sure Naja would agree that those rounds are really important. And as a chaplain, also that's the sort of thing that I would be able to help assess in these situations.
I think they're not only important during a hospital stay, but I think they're also important once somebody discharges. Because once they're out in the community, they're kind of on their own and just have that support system. So it's why it's so important to identify it here. So when you have someone who discharges in a less than ideal situation, you can try and put as much support around them to help make them as successful as possible outside the hospital.
We turn it over to the audience. Any other suggestions or comments or questions for our panel? Any other things that you would do in this kind of case? We'll have a microphone come to you.
Thank you. Based on the case, I'm having a hard time to believe this person completely lost his capacity, and the capacity is kind of like just for this particular issue, because rationally he is able to say, I came like this, I will die like this. And is there some sort of kind of like resistance of disfigurement? And accepting the limitations is always a challenge. And I work in the field of organ donation, and always people say, oh, what happens on the day of resurrection, I will not have my heart. So losing part of the physical body, how that affects, gaining your trust, how that is.
I can talk a little bit about that situation because, it has come up before. There are some faiths that believe, when they die, they need all of the parts, as you said, that they came here with, when they go to, the next plane. And oftentimes we get called, well, how do we facilitate that? How do we operationalize that? And we typically, I'm not sure if there's a policy about this, but generally it is treated as medical waste, which is an unfortunate name for it, but it can be handled by funeral homes. And funeral homes can take possession of those parts and hold them up until they need them. That way that they have the whole, and that's typically what we've done in the past because they're able to legally take possession of body parts or whole bodies, I guess, at the time that is needed.
Because it begs the question, you want to ask the patient, a specific question of, are you worried about bodily integrity? Is one of the reasons that you are refusing the surgery is that you don't want to lose a limb for this reason. So you don't know the reason for their refusal until you ask the question. Maybe it is a directed question like you propose. Any other thoughts from?
And even if it's not because of a religious belief, it's just so psychologically traumatic to lose a limb. Just isolated from the whole spiritual or religious aspect. For a lot of patients, that's something that's unthinkable. And it can really take a lot of, they have to come to that understanding over time sometimes. It's not something that they can make a decision on very quickly.
Especially a patient who is chronically ill, right? You've been chronically ill your entire life, and then you're gonna lose them. Now, what's next, right? So a lot of layers to that processing that needs to happen for maybe someone who might have some challenges processing that sort of thing.
And they can even see that as, that's just the beginning. So, first they take them, but
And maybe an opportunity for the team to describe what options are if you have an amputation for prosthesis and, ability to be mobile and walk and so on after the fact. All right, well, we'll move to the next case. So this is ET, 35-year-old male, was an unseatbelted driver in a motor vehicle accident. He sustained massive trauma and cervical spinal injury resulting in quadriplegia. He underwent emergency trauma surgery and has since been stabilized in the surgical intensive care unit. He remains intubated, and they are gradually trying to ease sedation to the point that he's able to answer yes/no questions. They think that he's still got brain function, so they believe that he has capacity to at least make some decisions and may be able to participate to a limited extent in more complex decision-making. The healthcare team has had discussions with the patient's husband, who reports that when they got married, they had end-of-life conversations, actually discussed some of these things, and the patient indicated he never wanted to be kept alive on machines. It's possible that the patient could be extubated, but there's concern that he can't manage his secretions, and if they extubate, he might need to be reintubated, for his respiratory function. So the healthcare team is of the opinion that, to help him transition off of the ventilator, it'd be good to have a tracheostomy placed. And if that were in place, he might be able to better respond to questions, might be able to use a talking trach and respond more than just yes/no questions. So there's this question of how do they talk about the tracheostomy? How do they go through the consent process? And a patient that can nod and shake his head to questions, but doesn't have the ability to write, doesn't have other means of communication. How are they going to engage the patient in the consent process? Let's turn it over to our panel.
So it really is important to listen to the family and hear them out and hear, you know, kind of all about the patient, let them tell you the story of the patient and what he was like and hear, you know, kind of the thoughts that he had expressed. But it also is really important if this patient has the ability to understand, to at least see how he wants to participate in that decision making. And certainly it's challenging, as Mark said, you can't write. There are other devices, but I think if they can lighten the sedation and you can at least start with those yes, no questions, and have, again, try to have conversations with them. You know, in this case, other people that are around the patient, the staff, you know, some of the other disciplines can also let you know what their interactions with the patient have been like and how much the patient seems to understand. But start with, you know, really simple yes, no questions and get a sense of, does he really want to participate? In this? It's also, you know, in some situations, the family doesn't want the patient to leave their status. So you kind of have to figure out how do you help the family feel more comfortable with letting the patient know kind of where he is and how he can participate in those things. There are also devices that you can use. You know, that is, again, nothing straightforward, but there are things that people can use their eyes for, and different types of boards and blinking and nodding. So you really can have conversations with therapy.
I also think, one of the things that's important is to recognize that we say that we would never want something years and years down the line, and we have no idea what that would look like, right? And so I think having a conversation, with the husband and recognizing that in this moment, it would be great to understand what he thinks now. Because what he had thought then may be different now that he's experiencing it. So helping someone and helping a family recognize that in the moment, the person can change their mind. And so it's really important to try and get them as clear as possible to help understand what they're.
I would just add to that, you know, we don't know the family dynamics between, in this marriage. We don't know if they're on good terms even right now. Family members are really helpful in that they know the patient, they know the way they make decisions, they know what their preferences are. They can put themselves in their shoes and kind of, you know, help to say, well, this is probably what we would have wanted. But at the same time, family members bring their own agenda, they bring their own biases, and the emotions of the moment can really come into play and affect objective decision-making. So it's a lot more complicated than you might think on the surface. And it takes a sort of a holistic assessment of the situation. You have to assess the husband who is not injured. You have to assess the patient. And again, another thing that I look at here is how much information are we going to really be able to determine about patients' decision-making capacity. As Sharon mentioned before, every determination of capacity to make medical decisions is dependent upon that decision. So it's not just, yeah, this person has capacity, they can make any decision about their medical care. He might be able to make a decision about whether he wants something to go to sleep that night, but he may not have the capacity to be able to understand the complexities of what's happening with this tracheostomy. So it's how do you assess that in a patient who can only answer yes or no questions? And yeah, it gets to be really complex. Trying to do that, trying to figure out if they understand the situation, they're able to evaluate their situation, and they're able to communicate effectively about what their desires are.
So there's a couple of things that I noticed with this particular scenario. One is that it, for me, clarifies the rule that as long as a patient can communicate by any means, whether it be blinking, you know, moving his or her eyes from side to side, they're nodding, there are a lot of different ways that one can communicate, but as long as there is some means, then they can be assessed for capacity. Now, that doesn't necessarily mean that they have capacity. It just means that you can go forward Additionally, Maryland law allows in situations where the patient is unconscious or unable to communicate by any means, rather than having the requirement for two providers to assess or to, I guess, assess incapacity, to certify incapacity. Maryland law allows only one provider in that situation. So in cases where the patient can't communicate by any means, only one provider's certification of incapacity is required in the record. Additionally, I think it's interesting that the husband's recollection of what the patient's wishes are different from, but maybe different from what the patient currently wants. Now, it's important to remember that even though patients may come in with things like advance directives or wills or MOLs indicating what they would have like done, if they have capacity, then they can always make the decision to contradict those previous decisions. Obviously, if they're saying, nope, I didn't mean what I said in that, document, and they are deemed to have capacity, they have the right to make that decision.
I think sometimes too, families feel like, if I make the decision for a trade, say, that's gonna commit that person to, every other procedure and every other, care thing down the road, but it really is steps. And I think the more, if the tracheostomy is going to mean that the patient is going to be able to participate more in decision making, then they should at least be offered, that and be able to participate in that. I think, sometimes families think this is not the life I want. They're traumatized. It's been something that happened very suddenly. And they're still grappling when this person's life has changed. And how do I change to start thinking about things a little differently? So, that's something that we all can help with.
Sharon, you had said, some families may say, well, don't tell the patient, don't tell a loved one what's happened to them. It sounds like you're advocating, you would want to tell this patient who's conscious, you've been paralyzed. Do you understand? Yes, no? Is that how you would introduce the idea of what their condition is?
I think if the family, I think having a conversation with the family and saying, it's important for them to understand what decisions we're going to be asking them to make and what's happened to them, and making sure that they're okay with that, because you want to also maintain that relationship with the family. But I think, yes, we kind of have an obligation to give that information about their care.
I think you can do that with helping the family understand that every single one of us has a right to know what's going on with our own body and be a participant in decisions related to our own body if we are capable of doing that. I think if you can help families understand it in a way where they're trying to protect their loved one, but this is also protecting the loved one by allowing them to have their.
So concerned about the emotional of getting the news, but the importance of conveying the news so they can make a decision about their body.
Absolutely.
And how would, apart from talking to the family, which in this case, the husband, about, we need to have this discussion with the patient, how would you ask the patient about the involvement of the husband in the decision? Any thoughts about that?
So you definitely can start with the patient of, do you want to be involved in making decisions with your care? That's a yes, no question. I think how we've approached it with other patients when we asked about, we can ask specifically, do you want your husband involved in helping you make those decisions? Again, yes, no questions. You can give them, do you want a little bit? Do you want a lot? Do you want a medium amount? Try to phrase it so that they are questions that are possible for someone who's not able to communicate verbally in a way that they can.
Turn it over to the audience. Any suggestions or thoughts about this case? We'll wait for the microphone to start.
Well, it seems to me that assessing this patient's capacity is a critical starting point for a lot of this. And if it can't be determined whether or not he has capacity, doesn't Maryland law give the authority to the husband, spouse, to make decisions for the patient, or if there's an equivocation over whether capacity is present or not, how would Maryland law address that?
I think that one's great. I would say, capacity is not an either or. You can't go on to the next step unless capacity has been assessed. You can't go to the Healthcare Decision-Making Act and determine who's the appropriate surrogate decision maker in the event the patient is incapacitated unless you have that certification. So, it is kind of like you can't go past that point until you've determined or had two physicians certify that the patient is lacking capacity. Now, once we've gotten to that point, assuming that the patient has been certified as incapacitated, then the Maryland law provides a hierarchy of surrogates, assuming, of course, the patient doesn't have an appointed healthcare decision maker. That's always the priority or the top of the hierarchy. Is if the patient has appointed somebody in advance directive or medical power of attorney, but there's some sort of documentation or indication from the patient when he or she did have capacity of who they wanted to make medical decisions on their behalf. And then once, if you don't have an agent, if you don't have any kind of advance directive like that, then Maryland law has the hierarchy, and it goes legal guardian, which is per court order, a spouse or domestic partner, adult children, parents, adult siblings, and then if none of those exist, other relatives or friends, assuming that an affidavit of relationship has been signed by the decision maker. I don't know if that answers your question.
Partially, I would just ask this, if it can't be determined, if the evaluator can't say for certain that the patient has adequate capacity to make these decisions, would it then fall to a two-physician panel to make that judgment, or would it still go to the spouse for the hierarchical arrangement you just discussed?
So it would only go to the spouse if there was two physicians who were willing to certify. And as someone else mentioned before, the base assumption is that a patient has capacity. So it's a pretty big hurdle to overcome, or at least it should be in any situation. It's not an assumption that you would override lightly. So if you're struggling to have two physicians certify, then what I would do in my role as, counselors, I'd say, well, is there a reason for that? Are we sure? Do we need to have additional, do we need to have an additional provider come in and act as tiebreaker as a sense? But that's kind of where I would go in situations where capacity is difficult to ascertain, because you're right. I mean, there are definitely situations where it's not black or white. And maybe, like I said before, it changes over time. But again, before relying on any alternative decision maker, you have to certify incapacity in the record.
I'm just going to piggyback off of this gentleman. So who chooses the positions? And then what type of positions are they? Are they neurological or?
Well, so Maryland law is not very specific. They don't articulate which provider. It's just generally speaking attending. Now, there may be clinical leadership and clinical considerations that go into that, decision. And I would typically defer to the clinical team because again, the law defers to the clinician's determination in their best professional judgment. And that professional judgment, that gives you a lot under Maryland law. But unfortunately, that's not something I have, or anyone else in the legal department. So if there's, I think, dispute about which providers, my general advice, which again has happened, my general advice is go up through your clinical leadership.
So it would be, the attending physician has to be one of them, according to our hospital policy. The second has to be a licensed physician. That's generally going to be another attending physician. There can be fellows and residents that have their own licenses in the state that might be able to be the second certifying physician. But generally, you know, if they're trainees, they're only under the auspices of the hospital, so they don't have their own license. And then it's generally going to be the physician that's responsible for the particular treatment decision. So if we're saying capacity is decision dependent, so if it's for the tracheostomy, it might, for instance, be the otolaryngologist, the ear, nose, and throat doctor that would perform the tracheostomy, who could be the second physician in addition to, in this case, the patient's on vascular. No, this is not the vascular surgery case. This is the trauma case. So it would be the trauma surgeon. That would be the attending physician, and then a second physician might be like the one that would perform the tracheostomy. Questions about that?
I'm just thinking, if you're having difficulty assessing capacity because of the ability for the patient to communicate, then that puts a responsibility on the clinical team to say, okay, what are all the means possible for us to be able to get this patient to be able to communicate with us? So what are their devices, or, you know, what are the things that we need to do? Is it something, you know, do we have to wait so that we can lighten up the sedation? You know, we have a responsibility to make sure that we're doing everything we can to let this patient be able to speak for themselves.
And if it's in the intensive care unit, so the other thing in terms of attending physician might be some intensive care units, the attending in the ICU, the intensivist is the attending record. And in the surgical intensive care units, at least at this hospital, it's the surgeon that's the attending record. The only reason I bring that up is when they are doing this, you know, additional information, maybe the intensivists are going to be working on the ventilator so that the patient could come off safely without the need for the tracheostomy. So maybe while you're buying time, they can be working on the respiratory status, optimizing that to eventually extubate the patient so that he could potentially talk on his own. Any other thoughts or comments or questions?
So psychiatry is not required to be present for each one of the decisions?
No, so psychiatry can be an option, but generally they will only want to be involved if there are concerns about a psychiatric condition. So if there's a delirium, if there is mental illness that might be impacting on decision-making capacity, then it makes sense to ask a psychiatrist to be involved. But generally it's going to be whatever service that patient is on, the attending of that service is the main one responsible, and then they get the second certified physician. Okay, here's the next case. CS, she's a 24-year-old woman who is 37 weeks pregnant and presents to the hospital in preeclampsia. She's an undocumented immigrant and speaks a South American dialect for which the hospital has no available interpreter, either in person or remotely. Her husband is present and speaks the same dialect as her and very limited English, but really not enough to communicate adequately with the teams. The obstetrician wants to recommend a cesarean section because of the preeclampsia, but really has no means of communicating with the patient and no means of checking her understanding because they can't talk in her dialect. What she understands of surgery pursued, the risks and benefits, why it's being done in the first place. So in this situation, we have a patient that can communicate, but just not in a way that we can communicate back with them. Panelists, any thoughts about this?
Well, we do have in our policy, accounting for this type of situation. If you contact the translation services and they don't have the precise dialect, the policy states that if attempts have been made to obtain a qualified interpreter through any and all of the approved modalities, but one not immediately available in the target language, then a family member or friend or another available resource may be used until a qualified interpreter can be secured. But this is the key part, is that attempts must continue to be made to secure a qualified interpreter in partnership with JHM Language Services. So this is kind of it's almost like an emergency situation, but it sounds like based on the scenario, the husband may not have, full comfort speaking English as well. So, it's important to, again, try and find alternative, either family members or other people in the community that might be able to, translate, as well as continuing to work with JHM Language Services to see if somebody, either if it's from, a Zoom connection or, other sort of, a resource that they're able to provide, until they can find somebody that speaks that dialect.
You may be able to find somebody in the community, somebody in their church that can communicate with them. We have a large Hopkins community, but you do try everything you can to find somebody that can.
And I think it kind of hinges upon how emergent the situation is, as well, that has to be taken into consideration. Right? You have to balance the communication, how full that communication is with the urgency of the situation. Ultimately becomes saving possibly her life, if that's what it comes to. So if we have to, you do the best you can for the husband, whether that means getting a sheet of paper and drawing what you're gonna do, whatever it takes to be able to try to express things to him. If he's able to get somebody on the phone, perhaps a family might mention the family member might be able to speak a little bit more English, someone that he knows. That's another option as well. But you just have to do the best you can, and under the time constraints that are present because of her condition.
There's that creativity of getting someone on the phone. It could be his employer, it could be, the neighbor. There's someone who knows the family that can probably speak some type of English enough to get the communication across. And so it's just a matter of helping them figure out who that is.
Could you comment on the emergent situation? Let's say that we're monitoring the pregnancy and there's the potential fetal, compromise that really feel that there's an emergent need for a C-section. And trying to use the time they have now to find another interpreter or someone that can speak the dialect. But if it really becomes emergent to either the mother or to the unborn fetus, how would the team proceed?
So, generally, I'd like to make the point that even if a person lacks capacity and an emergent situation develops, the clinical team is allowed to stabilize the patient and act in their best interest. It's important to note, though, in an emergency situation, we as the clinicians, providers, we cannot make decisions on the patient's behalf. All we can do is stabilize the patient so that the emergency is no longer present. If we were to, if we wanted to be in a position where we could make decisions for the patient, we would have to seek guardianship. So it's important, and then there's also particular documentation that you have to make in the record in an emergency situation when you are getting informed consent. And in this situation, it would be difficult to determine capacity, but I guess up until the point that this patient loses capacity, we could not proceed until we were able to get either informed consent from her or or unfortunately you would wait until such time as she couldn't be either unconscious or incapacitated to then be able to act in the event of an emergency situation.
Okay, we'll go. Wait for the microphone.
What? So social worker, so just as, yeah, but what constitutes the difference between, I mean, in some instances I can think of it, but stabilization versus decision making, right? Like, in this instance that you went further and described, you know, once she became critically ill, basically, and it was a life-saving intervention, then it's stabilization, but how do you decide the decision of C-section versus waiting until she has a standard vaginal delivery, like, what? Am I?
What's the difference between stabilize and
Right.
It's a fine line, I think, as far as, well, first off, you're taking the position, you know, the law looks at situations like this, and whose, life or bodily autonomy is imminently threatened. That's the standard. And it applies to the patient. It doesn't apply to the fetus, at least under Maryland law. So that's, that, I don't know if that goes to the question. So from the perspective of the patient, whether or not, her life or, you know, her life is imminently threatened, that's when you would intervene. And up until the point that her life is no longer an imminent threat, that's when the law at least considers it to be stable. So you're not making the decision to go forward with a C-section or a vaginal birth. It's more thinking about, okay, how do we, you know, stop the imminent threat? At least that's the way the law looks at it. I know, obviously, in practice, that can be really difficult determination to make. And that's why I think it is important to make sure that in situations like this, the whole clinical team is in agreement. That it's been, you know, and again, we try to buy time in these situations for those types of conversations, to explore the alternatives, to try and find somebody who can translate this particular dialect to, you know, up until the point that those types of decisions can be made. Does that help answer this question?
Well, it's sort of similar, you know, in the trauma service, the patient is in a car accident, is rushed into the emergency department, has chemothorax, needs an emergent chest tube. There's not enough time to do an informed consent process. You have to put in the chest tube, despite their protestation, perhaps, that I have to do this in order to save your life. I'm going to put in the chest tube. So we're saying it's only at the point where her life is in danger. You know, she had, you know, preeclampsia has progressed to malignant hypertension, and she could die just from this. The treatment for preeclampsia is C-section. So the way to stabilize her is to, you know, perform the delivery.
I guess one of the things I'm surprised that in discussion is that there's no talk about type of like baby. I'm sorry, there's no talk of what? Saving the fetus. Like if it gets to that point, the discussion is really focused on mom's consent
Yeah, I think that's
to
probably,
the demise of the baby.
I think that's probably a much broader conversation than we have in the couple
We're only
minutes.
narrowing it to the decision making. So we're not,
Yeah.
we're not even saying that she's refusing a C-section.
Right.
We just have no means of communicating to her about it. It might be that she's perfectly agreeable to saving her life and her baby's life by performing the C-section. We just haven't been able to communicate that. But a tricky situation, more difficult because of the communication part. All right, we'll move on to the next one. So this is BD, a 65-year-old woman who sustained a multi-embolic cerebrovascular accident, stroke, resulting in severe neurologic deficits, including hemiplegia, so loss of function on the side of her body, and mental slowing. With her cognitive impairments, she has no safety awareness, needs repeated cues from physical therapists when completing activities of daily living or walk. She is easily distracted. She is able to communicate, but seems to have impaired problem-solving skills. So with the occupational therapist, she's been asked to fill a pill dispenser. She's asked to describe the instructions of how she prepare a meal at home if she were discharged. So they really don't think she has this problem solving. Her hospital course is nearing its end on the neurology service. And so they're talking about a discharge plan. The physical therapist, occupational therapist, speech therapist, all recommend subacute rehabilitation after the hospital stay. BD refuses to go to subacute rehab, indicating that her mother had a horrible experience when she lived in a nursing home at the end of her life. So the patient insists on going home. Her two adult daughters in this case, think that this is a bad idea. Her daughters think it's appropriate for her to go to subacute rehab. They say, we really can't check on mom if she went home. They're working. They wouldn't be able to check on her regularly. No one else is at home. She would be there by herself. So the healthcare team is concerned with her inability to manage her medications and cook if she went home. So concerned about a safe discharge plan. And while they're worrying about this, they're concerned that she's going to say, I just want to leave the hospital against medical advice. So psychiatry is asked to consult. This is one where they did ask for psychiatry input. And they do not think the patient has capacity to make decisions regarding the discharge plan, at least for that particular decision. The attending physician on the neurology service, however, disagrees and is not willing to designate her as lacking decision-making capacity. So they call an ethics consult. So suggestions from our panelists, if either you were a member of the team or you were a member of the ethics consult service, I get a person.
As a social worker who does discharge planning, I didn't have family meeting immediately. I wanted to get people on the same page. It sounds like you've got multiple people on different pages. And if you can get everybody in the same room to have a conversation, then maybe you can tease out where people are thinking she has more cognitive abilities than she may actually have.
I think too, and you know, as much, you know, she may be refusing to go to rehab, but if you can kind of take a stepwise approach with her and her family and say, okay, you know, if your goal is to go home, how do we get you there safely? And maybe it's going to a place of your choosing. Let her participate as much as she can in her care. You know, knowing that the feeling home is not the safest thing.
I also think as you are looking at a plan for discharges, you're looking to get someone home or you're looking to take someone home from the hospital. If you are beating your head against the wall because that plan is not working, it's because it's the wrong plan. And so what do you need to do to either supplement that plan or change that plan so that it actually fits the person that you're trying to.
Yeah, I think from a legal advice perspective, we always do try to return to, is the discharge plan safe? And I know that's not always an easy evaluation to make, because again, it kind of returns back to the idea, is there an imminent threat to the patient? If they were to walk out the doors, were they, do they have a central line in? Are they going to bleed to death imminently? Those are kind of the questions that, at least from a legal perspective, we tend to ask when the question becomes, is the discharge plan a safe one?
And I'm looking at it from sort of an ethical standpoint. It really hinges around the patient's capacity to make an informed decision and to be able to fully understand everything that's been presented to her and what the consequences of that is. Because you're basically balancing her own autonomy, which is an ethical principle that's very important, especially in healthcare, with the principle of doing no harm. And if you're sending her home into an unsafe environment where she's just going to end up back in the hospital or possibly much worse, that's nothing that anybody wants to live with. Nobody on the medical team wants that. So it's a really that's the dilemma as I see it. And that's why the determination of medical capacity in this case is so important.
It's a tough one though too, because even if, you determine that the patient does not have decision-making capacity, she's verbalizing that she does not want to go there. So we're essentially going to be forcing someone to go someplace that she doesn't want to go to. So like Elijah said, how do you look at a safe discharge plan, but something that might be different? What support can we try to get for the family so that we can at least do a trial and make it as safe as possible?
Can you comment on the dispute that the attending physician in this case is not willing to certify the capacity, although we have a psychiatry consultant that thinks the patient lacks capacity?
Yeah, so, this can happen where we have disagreements, and oftentimes, or sometimes they'll come to legal to be the tiebreaker. That's not our role, unfortunately. We do, tend to, ask questions about, who's the appropriate licensed physician as far as, making the determination for what they're making a consent, or taking capacity for. And otherwise, what we tend to recommend is going up to clinical leadership.
There could be the potential of getting a third attending physician as a tiebreaker to help this attending physician making the determination.
And then I also think too, when there is any type of disagreement, there's disagreement with family members on a particular situation, or there's disagreements among providers, it can be helpful to engage the ethics team as well.
And I also think it gets back to what Naja said about having a family meeting right away. Let's communicate about this with all the family members, with the patient, with the team. Let's all put our heads together and see if we can come to some sort of agreement on this. Because, as we know in hospitals, oftentimes communication is between two people here, two people there, and just to get everybody in the same room could be really helpful.
And that can be the role of the ethics consultant, is to gather the disciplinary team, the family members, with the patient, and just be the neutral party to make sure everyone is heard. Negotiation as might need to happen can occur. Thoughts from the audience? So it's again just working with all the involved parties to try to come to some solution.
I have one question. What if there's no family?
So you do, you can find somebody that this person is, connected with. It could be somebody that they live next to, a friend or whatever, and try to engage them if you can. If, social work does that online for us, if we try to research and try to, find people that are connected, because those people are connected to somebody. But occasionally we do have people that don't have anybody.
I involve our wonderful legal team and look to seek out guardianship, because there has to be somebody that's making decisions for that person, and it needs to be the appropriate person. So if we can't find somebody, then go through the court system.
Assuming they lack capacity.
Yes.
Yeah, again, I know I was on that broken record, but the threshold question, any situation like this is assessing capacity. Because once you do that, you can determine, okay, if we have to work with a patient, and that, involves some negotiations and creative solutions as to what would qualify as a safe discharge plan, then we would work with the patient. If the patient does lack capacity and there's no family members or other authorized decision makers, then you go back to the Healthcare Decision Making Act, the hierarchy, and work your way through that. And then also, as you mentioned, is if there's absolutely nobody, but we find it's a case that we need to intervene on and make decisions for the patient, then we would go through the court system and seek guardianship. But that's not a very instantaneous solution, as you may, I know I know I get calls sometimes, asking about, starting guardianship procedures, but I should know that can take time. That's another consideration.
I guess the other point is, if she were determined to lack capacity, so a little different than as this case is presented, and two physicians have certified that the hospital has means of detaining the person so they don't leave against medical advice.
Well, they wouldn't be able to leave against medical advice because only somebody with capacity can leave against medical advice.
So if they were trying to walk out the door,
Yeah.
they could
Yes.
be detained because
Correct.
they're a vulnerable person. Any thoughts, comments? All right, then I'll give you a summary. So as we said at the beginning, patients are presumed to have decision-making capacity until proven otherwise. The attending physician and the second licensed physician are responsible for it independently, so they have to do their own separate assessments and document that the patient lacks capacity, has incapacity. The team members can aid in the assessment and raise concerns when they think that there might be a patient, their question, is that they may not be able to participate in the consent process. And then when a patient is determined to lack capacity, you need to find an authorized decision maker to make decisions on their behalf. All right, so we will conclude it there. Thank you to our panelists and thank you.
Thank you.